Sweet. So awesome. All right, Michael, could you please just give like a brief background on yourself and then we can go straight into it.
Sure. Yeah, have been at Washington University since 1981, and my career started as a physical therapist. And I was very interested in patients with amputations, and then became through the work of Paul. Through a number of different areas, I got very interested in the diabetic foot and injury to the diabetic foot, then thinking about how stress affects tissues. And I got my PhD and did a lot of work, a lot of research in that space in the area of preventing lower extremity amputation. And the physical stress theory kind of came out of both that clinical and research interests.
Perfect. So do you want to share your screen and go straight into the slides?
Sure. And I would just encourage anybody to interject as, let's see, let me get this, see if this is the right one. And why isn't it? This is a second. Yeah. So as I told Chris, this is your time, and I want to be respectful of that. I have some slides that this particular kind of a paper it may be different from what you've done in the past. You know, when there's a data-driven paper, there is, there's more opportunity, I think, for some give and take. But on a theory paper like this, I don't want to minimize your questions or talk over what you may be interested in. So at any point, don't hesitate to stop and say, you just want to discuss, you have a question or you have a comment. And so before I even get going, is there any questions that y'all have? Any burning issues before I jump into some of the nuts and bolts of this theory?
I just want to say that you're a legend, and I hope over the course of the however long we spend, I'd love to know if you had to rewrite this paper in 2021, what you would do differently.
Yeah, that's a great question, Travis. And so let's come back to that at the end because I actually took a sabbatical a couple of years ago and considered that question very carefully. And I might even turn it back on you a little bit and say, what would you like to see in there in regard that isn't in there? So that's a great question. Okay, and we'll hit that and any others that come up. And the only reason I'm delaying it is it might be useful to come back to that actually as where do we go next on it? It's a great question. Okay, so the basic premise is what you see there in the figure, and it's a theory. And so as I said before, it's different from a data-driven paper, but I'm intrigued by theory. I think all of us, whether we know it or not, live under different kinds of theoretical premises. Maybe it's your political bent, maybe it's your religious bent, but there's these ideas and beliefs that kind of tie together and lead and have a great influence on what we do. And certainly, the periodic table is one great example that started out as a theory, but then became more of a law because the founders did such a good job. So what was cool about this is that not only did it kind of tie together areas, but the people who developed this, there were holes in the table, but they predicted that elements would be in these particular places, and lo and behold, it was exactly what they said. So not only is there the idea that theory can tie ideas together, help you to understand phenomena, but a good one will help you predict moving forward. And so this is very much a big picture. It doesn't specifically direct treatment, but you can deduce treatment from the theory, and we can talk briefly about that. Physical stress theory, why physical? Well, at least I'm a physical therapist. It sounds like many of you are physical therapists. And so I like the idea of that. It's according to the laws of nature, produced by forces of physics. And as you know from your basic physics, that stress is equal to a force divided by an area. And so then movement, when you think about movement, there's been this huge focus onto movement in our profession in the last couple years. And if we think about our focus, it's very much controlling the physical stress on our patients to cause a positive change. And our primary tool then is movement. And our current vision statement, transforming society by optimizing movement to improve the human experience. And I'm for this vision, but it's a little touchy-feely too. It's a little out there. In fact, in the sense of movement, what's the science of movement? And I think as a profession, we are trying to develop movement science, but how does movement relate to the patient? And so this is about how biological tissues adapt to physical stresses in very predictable kinds of patterns. And you can see that in the table, but I think I probably deleted these slides, but if you think about movement, movement is a mass acceleration of a body part. I go like this on my movement, so it's a mass acceleration. And what is mass times acceleration? Anybody?
Force.
Yeah, force. Good. So mass accelerated is equal to a force. And then, that's transmitted through an area on the body and you get stress. And so then our bodies are incredibly designed to adapt to that stress, to respond to that stress. And so a key point that I think, is important to understand, it's all about change. Change in the relative level of physical stress is what causes the predictable response. And so there's these basic 5 windows of adaptation. And I'm going to move through this pretty quickly because I think it's pretty intuitive, and I'm going to assume everybody read it, but don't hesitate to stop if there's questions. And so you can think of all that we do and the stress that we give to our patients, the stress we apply to the patients, or the stress as an individual that we experience can be placed somewhere in this spectrum. And so physical stress is on the y-axis. And, for all of us, wherever we are, if we're steady state, if there's no change in our stress level, we're in this kind of maintenance window. And it's just steady state. I've kind of thought, getting back to your question, Travis, about what I would do different. One thing is I wonder even if this maintenance window exists. I wonder sometimes if it's just, we're always either excessive, putting more stress on, or we're resting and we're doing it. And there's just this constant give and take. But yet I still believe there is this, certainly from a theoretical standpoint, it makes sense. But when there's overload, and the key principle here is, you could think about it as hypertrophy, but the more fundamental idea that I think is transforming in clinical practice is that you have increased stress tolerance. Overload, give any tissue more stress, and it wham, it adapts to it. I mean, like, how cool is that? It just changes in its basic structure, its basic molecular, its physical structure, and is able to accept that stress. But then, you don't want to get too high because you're going to get injured. You exceed this level, this whatever that level is, and it's you get injured. And where I'm here with my grandkids and no TV, and we watched a Star Trek movie not too long ago, and man, I wish we had one of those little things that we could go over the tissue to know where this threshold is, because then we could give much better feedback to patients. And so this is a little soft, this window here, and this is where our clinical expertise really comes in. How much can we push the tissue without injuring it? And likewise, if we have prolonged low stress, you go down here, and we can think of that as atrophy, but it's really, from a physiological standpoint, the atrophy is what results, but from a functional status, it's the tissue that becomes less tolerant of stress. There's these lower set points. And I think, what's really critical, thinking about working with patients is, I believe that all of these levels decrease. There's that each one of these kind of ramp down. And I think there's pretty good evidence for that. All musculoskeletal problems become more common the less conditioned people are. And kind of the prevention for musculoskeletal problems is a high general activity level, something that increases the stress level and raises the this threshold, which is what you do when you overload. So you overload, you go above the stress top, the maintenance level, you get into here, and boom, all of these things kind of ramp up. And again, I'm going to come back to your question, Travis, as we go along. I mean, since this paper, there's just loads and loads of other kinds of beginning papers, beginning evidence or developing evidence that show this is true. I think one of the most recent ones is with cartilage. I have believed for many, many years. So I said before that the theory can be used to predict, and that's what helped me a great deal in my research with the diabetic foot, because the traditional wisdom was just protect the foot. Don't let anything happen to the insensitive foot that can't feel pain or pressure. It came out of Paul Brand's, a lot of Paul Brand's work in the 60s. You got to protect it. But what happens when you protect it? You keep protecting something. You keep sheltering. You have stress protection. Well, you just make it more and more susceptible to injury. And that's exactly what we found. We did a number of purposeful studies. There actually was some work that came out of San Antonio and David Armstrong and other places, that with the diabetic foot, the longer it goes, the more susceptible it is to skin breakdown. And so even tissue like the diabetic foot, you can increase stress tolerance. And the first grant proposals I put through to say we were going to try to overload the diabetic foot, we were going to increase walking, they just got shot down because you just can't do that. You're going to hurt people. But we kept chipping away at it, and it eventually actually changed the guidelines. So over the course, it's probably been about 10 years now, the American Diabetes Association guidelines, the World Diabetic Foot guidelines have all changed to say it's okay now for people even with neuropathy to do weight-bearing exercises, with the realization that if you don't, you're going to, boom, go down. It's going to deteriorate. And so that comes to, injury. And so again, just a little background that doesn't come across as much in the paper that you might, but I had worked for years. I was trained generally as a physical therapist, and I became interested in the diabetic foot. And what was intriguing to me about the working with the integumentary system is it's all right there to see. You can measure the stresses on the bottom of the foot. This is a in-shoe sensor of someone walking with a neuropathic ulcer that doesn't have protective footwear. And you can see the ulcer that developed. These folks don't have any pain. They can't feel pain and pressure. And and Paul Brand is the fellow that was very instrumental. He was a missionary in India, and had worked. Has anybody heard of him before? Anybody on the call heard of a guy named Paul Brand? Well, this is worth your admission right here, because this guy was amazing. And if you Google him sometime, I haven't done that recently, but he was an orthopedic surgeon, and actually was a hand surgeon, but he worked with people with leprosy, with Hansen's disease, and he made all these incredible observations that led to an understanding and a connection to diabetes, because basically Hansen's disease and diabetes, it's the same mechanism of injury. They have this neuropathy that allows unnoticed stresses and leads to skin breakdown, amputation, to mutilations, as it was called back in the 60s. So he had outlined the three mechanisms of injury, which are, let's see, I think I didn't put it up here, but basically, there's three mechanisms of injury. Very high stresses for a short duration. That would be any kind of traumatic event, stepping on a tack, getting hit by a car. And then a very low duration, very low stresses for a long period of time. That would be a lot of our musculoskeletal postural problems, or wounds from being in a hospital, pressure wounds. And then the most common, though, and the one that you see here is the pressures that we get just during life. Moderate pressures that are repeated many, 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 many times. And so it became very easy to see and notice in the diabetic foot. But then as a physical therapist, it kind of struck me, well, this is the same mechanism of injury I see with every repetitive injury. Somebody with Achilles tendonitis, with other forms of just think about back pain, low back pain, any kind of tendonitis. So that's what, and this theory was kind of percolating for maybe 10 years over the course of time. And it wasn't until I had a PhD student, Katrina Malouf, who really kind of goaded me and into getting this on paper. And it took a lot. This was without a doubt the hardest paper, at least the longest time it took to write a paper. And I think, in my opinion, and I'm totally biased, of course, but the beauty of it is its simplicity. I mean, it's really pretty easy. And so some people, not surprisingly so, are not very enamored with this whole deal because, well, of course, it's kind of like, yeah, these are the things that we work with every day. But but I think the beauty of it is that it's kind of summarized in a very user-friendly way and something that can be translated to patients or to colleagues or applied. So this is a little.
Did you experience any like people trying to refute you, or people who are saying, "Oh, this can't be true," or it can't be this simple?
Well, no, Travis. In general, there hasn't been, except in the application to pathology. So in general, people, as long as you kept it general, I didn't get any arguments. But where I got pushback is when I started to say this is true with just about any condition. There may be some exceptions, but the really strong pushback came when I said, this is true with the diabetic foot. This is true with cartilage and osteoarthritis. And people just said, there's no way. And there's still people that kind of say that with things like osteoarthritis. Osteoarthritis, they say, well, that's because there's too much stress on it. Diabetic foot wounds, it's because there's too much stress on it. Well, yeah, that's true, but then protect against the very high loads, and let's hit that sweet spot in there where we can overload it and become more accustomed. And as I said before, the most interesting application I've seen is with osteoarthritis. The guy at, I think he's at Delaware, did some work where he looked at activity levels with people with osteoarthritis. But this is true with runners. This is true of all kinds of things, that in general, people, even people with knee pain, osteoarthritis, if you can get them to increase their activity level at a manageable level, they have less pain. And that's exactly what this theory would predict.
Michael, I have a question.
Does that answer? Yeah.
For you had written, I think up to the letter L, number of fundamental principles in your paper. And the first one, A, changes in the relative level of physical stress causes a predictable response. Do you still believe that there's always a predictable response with the relative level of physical stress?
I do. Yeah, I do, Chris. And your question, which I encourage him and am intrigued by, kind of infers that maybe you've seen someone that it isn't. So keep going, keep talking.
I think, like, I guess old school, like Hans Selye, like, like general adaptation syndrome, you have this imposed stress and you'll have, a similar response to it every time, or a stress response. But then I think the more I look into like some of John Kiley's work and some of like, subjective responses to stress, there's way more, I think, unpredictability with how people perceive stress, how they react to it, even if it's the same, objective amount. So I think that's where I was a little not caught off guard, but hesitant to say that it's always predictable.
Right. Well, that's a great lead in to the modulating factors. That's just a perfect lead, because you're absolutely right. I mean, certainly we don't all across the spectrum respond in the same kind of a way, because we have such different psychosocial and physiological environments. And so the pictures I showed you of this diabetic foot, there's no way that if someone with a neuropathic foot went out and did the kind of stuff that I do, or the stuff that most of you guys do, that they'd have a foot left, So they're going to respond differently. Their window of adaptation is much lower. But maybe I think I'm about up to that. This is pretty self-explanatory. The level of stress is, is relative. So you have to think about all these different ways. Chris, let me get through these couple points real quickly, and then I'm going to come back to your question, because that's basically part two. What you're framing is part two of the physical stress theory, table 2, or whatever the name of it is. So just quickly, physical stress is this composite value. It really does make a big difference about time, duration, repetition, the direction of the stresses. And then they combine to contribute to this overall stress on the tissue. So they have this memory. And again, this is one of those areas, Travis, that I had intended on my sabbatical to update, because this body of literature has gone crazy since 2002. When we wrote this in 2002, the glycoproteins, integrins, were just being described. They were very new. And now, there's whole journals on mechanotransduction and mechanical transduction and integrins. And this idea of, what's the mechanism of injury? And so, as you remember again from your basic kinese courses, there's this very fundamental stress-strain relationship in tissue, where stress is on the y-axis, strain, or the amount of deformation is on the x-axis. And, it's probably these sensors are measuring strain more than they're measuring stress. That's the way these integrins are set up. So, we've got these things in our, I'm just curious, how many of you have know about and/or have studied integrins? Not many. Okay, so this is like the fundamental sensor. So you think about a dynamometer as a sensor. It's got a load sensor. We measure strength, or a ground, or a scale, is a sensor for the weight, and it transforms it into something else. Well, these integrins are embedded in almost every cell wall, at least every weight-bearing cell, and they go from the intracellular matrix out to the extracellular matrix. And what they measure is load, and basically they get deformed in the extracellular matrix, and if they get deformed, they're probably the tissues that encode the adaptation. So it's kind of like these cells are, when we stress them, when we exercise, when we overload, they're saying, whoa, we got a problem down here in the central system of the cell, because I'm getting tugged and pulled, and you better put some more tissues in there. You better enhance the cytoskeleton. You better make me stiffer, because if you don't, I'm going to get torn apart, or I'm going to get injured. And so it communicates to the actin and the myosin and all the other intracellular myofilaments to adapt. Here's the three forms of the excessive stresses: magnitude, duration, and repetition. Inflammation, you guys know about. As soon as you get inflammation, it's an acute. You gotta protect it. It's a decrease in the stress tolerance. So as soon as you get inflammation, it's an acute response. Now the tissue cannot adapt; it's injured, and you have to protect it. So then, Chris, this gets to your question, this idea about modifying factors. So you are absolutely correct that all of us do respond in different ways, but I believe and I think what this theory has tried to do is you can think about that, and you can plan for it, and you can have kind of an a priori expectation of the way it's going to go. You can understand it, and you can modify your stresses accordingly. And so table 2 or whatever it is kind of defines that. And so you think about adaptation. This is, a Venn diagram where you think about different variables that influence the central. So you could think of these as all the independent variables, and the dependent variables are tissue stress. And the main one we think about, our kinesiology core, is the movement and alignment factors. So this is what we primarily think about, muscle performance, motor control, posture, physical activity. But there's these other 3 bubbles that we have to be aware of. And so, Chris, I think what you were talking about were the psychosocial factors, and what I talked about before, the physiological factors, things like rheumatoid arthritis, like diabetes, like peripheral neuropathy, that they definitely affect the way the tissues adapt. And so I'm going to go, movement. I'm going to go through that pretty quickly because that's like the heart and soul of what we do. I don't think anybody would argue that. There's that mass acceleration, extrinsic factors. I really liked it. In fact, before, I've always taught prosthetics and orthotics, and as a clinician, I was always drawn to prosthetics and orthotics because you can make such a difference so quickly in patients. And for the most part, I think it's because, you just immediately change the stress environment. So extrinsic, outside the body, can be modified by PTs. So this is just one simple example. You have somebody with low back pain, you put them in a 3-point orthotic device. We used to call these Hewitt hyperextension braces. I don't know what they call them now, but it prevents the person from flexing. It protects them from the stress on their low back. But here's I think what you were getting at, Chris, is the modulating factors of things like self-efficacy and things like depression. And so, Travis, to come back to your initial question, this is what I was going to put more in when I rewrote it, because this body of evidence has just exploded. You think about central sensitization and the effects that has on the tissue level. So let me turn it back on you all, and a question to anybody: if you think about central sensitization, how might you interpret what's going on there according to the physical stress theory? Is that a term you all are familiar with, central sensitization? Have you studied that? Okay. And maybe just, and if somebody could even begin, I guess, by just describing what they believe central sensitization is in the whole pain experience.
All right, I'll go. Well, one in the chat, Zachary said that it's the nervous system is hyperactive. I also kind of, you sort of think of, okay, as a stress is applied to a system, it accommodates, it repairs, so that future stressors might not cause the same amount of, well, I guess, stress and then adaptation. But then in my mind, that's kind of contradicted with, like, if someone becomes sensitized to a certain type of movement. So I'm not exactly sure how to delineate those two.
And give an example of that, Kevin. What would be an example of what you mean by somebody becomes sensitized to a particular movement?
Sure. So I guess this actually kind of plays into one of the examples of stress you gave, which was like a repetitive motion. But my interpretation in the past has been that as they're placing more stress on it, and sort of from like a psychosocial side, it's less about actual like tissue damage over time sort of accumulating. But that's just kind of an example. So say repetitive lifting and moving boxes.
Yeah, so I kind of think you bring up 2 points there, and going back to the heightened pain response without the physiological equivalent, on the periphery. And I think that's a key part of the whole central sensitization. And so in those people, for whatever reason, and there are these central factors factors within the central nervous system that have basically lowered the pain threshold or the injury threshold. So in the way I look at things, those kind of individuals who have a very heightened pain response, in other words, their response is way exaggerated to what we would think about it, their threshold to injury is just way lower. And so to me, the value of the physical stress theory is, well, there's still room for adaptation in there. And I think this is actually a perfect example, because historically, the treatment approach is kind of to protect these people. To protect, somebody gets a heightened pain response. Well, we don't want them to be in pain, so we're going to tell them, take it easy. Don't do as much. But what is the evidence showing? What is the better approach when someone has a heightened pain response?
Yeah, I mean, I think that kind of like the diabetic foot, it's not like you completely protect it, isolate it from any stressors, but rather find that room that you can modify without causing further tissue damage.
Yeah, absolutely. And it's almost like an act of faith, the way I think about it. I've just been reading some other things in that area. Sometimes it's like you just got to take a step forward, and you just got to go. And in this population, that's absolutely true. So you think that the best body of evidence is historically people with rheumatoid arthritis who actually have physiological. So that's not a good one. But the other one, what's the pain syndrome? I'm having a senior moment. Where you have generalized pain and all kinds of trigger points all over your body. You're oftentimes fatigued.
Fibromyalgia.
Thank you. It used to be the medical treatment was rest, and that's like the worst thing you can do. And so there's good evidence that says, get on a physical activity routine, kind of just stress and take some physical stress. Start out easy, start out walking, start out swimming, whatever. But there's no doubt that some form of aerobic exercise is good for it. Even when there is physiological and rheumatoid arthritis. When I graduated in, back in 1979, it was all about rest. You're supposed to teach them energy conservation. And then in the 80s and the 90s, I still remember her name, Marion Miner, at the University of Missouri, published a number of papers showing that you can do overload exercises, you can do aerobic exercise with rheumatoid arthritis, and they actually do better. They have less pain and more function. We saw it in myocardial infarction, and I think it's the same in these psychosocial issues. And so rather than being a contradiction, the way I look at it is it's kind of like that's some of the best evidence for it, because it's not what you would expect. It's kind of not what you would think. Now that window of adaptation is not as wide as it is in you or me, and that's why they're challenging. But that's why I think it's important to have patience and work with them to try to hit that. And I'm just looking in the. I'm just looking in the. It looks like somebody from JP says Dr. Malouf is my professor. You're at San Diego, JP?
I am. Yeah, she's great. She's one of the smartest people I've ever met. So
she is just brilliant, and was a big part of the inspiration of writing this. So be sure and tell her hello for me.
I will. Yeah, we were lucky enough to have this paper sprinkled throughout our whole curriculum, and I think that was part of it too. But yeah, I will. I'll tell her hello for you.
Great. Well, that's fun. And I see Zach has, Zach, you had another, let's see, nervous system is hyperactive based off of the PST. Could you assume these individuals will be moving towards an atrophy? Yes, absolutely, Zach. So if their physical environment, so this is the physical stress theory is all about just the physical environment, but you superimpose a psychosocial issue, whether it's depression or, hyperactivity to the to pain, or a hypersensitivity to pain, and you lower your stress, you'll have the results of that lower stress. Let's see, and from Jordan, do you think there is a ceiling effect for every person where the physiological reach maximum adaptation, and then after that point, no matter what, it could lead to injury? Or do you think if you modulate within that stress response, hypothetically, there will always be an adaptation, whether it would be for the better or worse? Well, I love that question, Jordan, because that's exactly the kind of thing that would stimulate to think of those. And what are some interesting examples? I mean, if you look at today's sports, I played basketball when I was in high school, and I look at these young men and young women who play basketball now, and it is not the same basketball. I mean, these athletes are several orders of magnitude higher than what anybody was doing in basketball. And football, you could pick any sport. It continues to go up, like even, you think about the 4-minute mile. That's one that hasn't, we haven't seen it tremendous, but every now and then somebody breaks through. So I think it's a great question, Jordan. And I think in general that I would say 99% of us are nowhere close. But there may be, theoretically, as much as you can do. Certainly, I think that's possible. Great question.
Michael, do you think that schooling and clinicians in general are too, they under stress or underload patients, or they're taught to be a little bit too anxious about pushing the envelope?
Yeah, another great question, Chris. I think the profession is catching up with giving adequate stress. But in general, I do believe we under stress our patients. Yes, absolutely. And I think we've done it for many years because we're afraid we're going to hurt them. And it's kind of, I've always thought it's kind of like this alpha beta problem. You do too much and you hurt them, but you do not enough and you're not doing them any good. And so I think in general, it is good to push the envelope within reasonable means. But of course, you have to be smart on those modulating factors. Just as an example, my father-in-law is right around 90 years old, and he was a very avid athlete in his younger day, and he would just go after it, no matter what. But he's had a stroke and he has really bad spinal stenosis, and he went to a physical therapist who was a sports guy. He primarily treated patients with sports injury, and he treated this 91-year-old man with spinal stenosis like he was 30 years old, and you just can't do that. So I want to answer your question, Chris, thoughtfully, in that I think overall we do understress patients, but it's easy to overstress them if they have some kind of a structural or physiological problem that causes them not to. And again, in my opinion, that's exactly why physical therapy is so important. That's why, and there may be trainers on here, and I have tremendous respect for trainers, and I think we need to work together. But a trainer doesn't have the background in the medical problems that a physical therapist does. And so that's why, I hear some people talk about gloom and doom on the physical therapy profession, but there's always going to be a need for us because we're dealing with movement, with function, with an understanding of those modulating factors.
I have another question. You wrote pretty early on in the paper, physical therapists have emphasized the evaluation and treatment of movement dysfunction. I'm curious what your definition is of movement dysfunction and if that's evolved over the past 20 years.
Yeah, I would, to me, I guess, you'll hear different definitions from different people, but in the context of the physical stress theory, I would say movement dysfunction is kind of a habitual movement pattern that places excessive stresses on a tissue that the body can't adapt to. And so that's where that whole idea of motor control comes in, so that the bubble, the movement and alignment factor bubble, includes motor control. And so you think, and I guess this comes back to the question earlier, is there a ceiling effect on adaptation? Well, certainly if you move, like for instance, I had back pain for years, and I had this hyperextension pattern in my low back, and it just became habitual, and it placed too much stress in my vertebral area, and whenever I'd get too active, I'd have back pain. And I saw Linda Van Dillen at Washington University, who looks at movement dysfunction, and she helped me alter that movement pattern. I don't have back pain now, and at the same time I went through the same thing with the shoulder. So we do develop these habitual patterns that a lot, even as a trained physical, you can't see it on yourself. At least I couldn't. And so I've had just these very short little visits, I would call them life-changing visits with my with a physical therapist for my back and my shoulder, where I learned how to move just a little bit differently. That meant the difference between having, chronic pain and not having chronic pain. Did that answer your question, Chris?
I think so. I just have a hard time, like looking at something and saying whether or not that's dysfunctional, especially with how much variability there is with, I mean, for example, yourself, you could be in a position that could, create some sensitization, but someone else could like feel amazing off that. So who's to say that one's dysfunctional or the other?
Yeah.
It's context dependent and person dependent.
So, and that's why, that you've hit on a key point of the physical stress theory. What difference does it make if that person has it? Okay, so if you're absolutely right. I still, so I was a foot guy. I treated lots of problems with foot and ankle pain, and there was this underlying note, excessive pronation is bad, and you're gonna have sore feet with excessive pronation. Well, the way I think of, and then, I've got a really good buddy, Dave Sinecor, who I've, worked with for years and years, and published a lot of stuff, worked together in the clinic. And we ran a half marathon together. And I looked at his feet one day, and they looked terrible. I mean, I thought, how do you even walk on these feet, David? And here he had just finished a half marathon, and he had no pain. But what if he did have pain? And maybe, and if you relieved the excessive pronation and he didn't have pain? Well, let me just be very direct and say, who cares if it's not on everybody? It's kind of like it's a risk factor, and that risk factor is there, and some people can tolerate that motion and some people can't. But if they can't, and if the pain is modified, if the injury is modified, if you modify their movement, well, that seems like a good move. That's a good treatment approach, which is hard. It's a very hard thing to test from a research standpoint, isn't it? But I think what we're seeing now is thinking about it more as a risk factor and trying to quantify those movement patterns. And again, I guess I would turn you towards the work of Linda Van Dillen, who is at Washington University and has identified these different movement patterns in people with low back pain. And she's published a number of randomized controlled clinical trials, and she's just completed one. I don't know if it's published yet, but I've seen the data, and it's really quite remarkable that, it's kind of like common sense. So too, and it's something that clinically physical therapists and occupational therapists have been doing for 40 years, at least as long as I've been a PT. We used to call it work hardening. You'd look at somebody, the way they lifted, and if they weren't lifting properly, whatever proper is, and you changed it, well, they tended to have less back pain. And so she's beginning to define that. And it's things, like moving at your hips rather than moving at your spine. I was taught that 40 years ago, but I don't know that there's been good evidence about that. I don't know that that's been quantified with three-dimensional kinematics and then put through a randomized controlled clinical trial to show that yes, indeed, it does make a difference. So, go ahead.
Oh, I just had a quick question. When you were talking about sort of with physical therapy, maybe changing movement patterns or things like that, if somebody's in pain versus not, whether they're flexion intolerant, extension intolerant, what have you. Do you think that those are like permanent changes, or rather just like a temporary position to offload the structure that may be sensitized, and then slowly the individual adapts, they kind of work back into those ranges?
Yeah, that's a great question, Dylan. And actually, what Linda found was that because she measured these with 3D kinematics and followed them over the course. I forget if it was 1 or 2 years, but there was a tendency over time to go back to their more habitual pattern. And she found that a booster session could make a big difference and get the person back on track. And so that's why I think, in the future, as physical therapists, I hope we get into the model more like a dentist. You don't go to a dentist one time and say that's a done deal. You're supposed to go to a dentist every 6 months or every year to make sure you're still brushing right and that there's not any problems going on. And wouldn't it be great if that happens with physical therapy as well, to kind of get a tune-up, if you will, on the way that you move. So go ahead.
Follow up on that. Did you know if that study showed that with the individuals that slowly started to revert back to those sorts of previous movement patterns, if that was more indicative of them having further pain?
I believe it did. But and if it's not on she's done at least 3 or 4 major randomized controlled clinical trials. So if you Google her or go to PubMed or whatever, when you get a chance, you'd be able to find the specifics of it. I may be getting it wrong, but I do absolutely know that that there was a recurrence, just like with all musculoskeletal problems. But then she was able to do this booster. We see the same thing with osteoarthritis. Kelly Fitzgerald and the work that he's done out of the University of Pittsburgh, a booster to get people back on track makes a big difference.
Michael, can I push back on the dental idea?
Yeah.
So I think I have some issues with the thought of like a recurring, maybe like 6-month or yearly check-in with the MSK provider. And I'm curious to hear other people's thoughts, because this just could be me. But I think, one, we're not great at assessing like future risk of injury in patients. So going to see someone who's not injured, or someone coming to see us, are we just creating like this kind of over pathologizing of movement, or making it, finding something because they're coming in? Or, are we using these sessions to like check in with them and just create a relationship and to like, compliment them on what they've done? I could see that being valuable, but I could also see it going down like a bad path if we have to like, tune them to like, they need to be fixed on like a 6-month or yearly basis. That's where I could see it being, potentially harmful.
Yeah, no, thank you, Chris. I think those are really good thoughts and help to clarify what I said. And so it wouldn't be exactly like a dentist where everybody needs to see a dentist, but those people that have chronic, maybe it would be better said, those with chronic musculoskeletal problems that they're dealing with. Because I hear what you're saying about the whole, and it kind of goes back to my Synacor example with the excessive pronation. And I'm a very strong advocate of if it isn't broken, don't fix it. So I hear what you're saying, and I think it's a point well made.
Yeah, that's what I was thinking too. Like, okay, people are coming in, if they're not in pain, well, we can identify 18 things on them: excessive pronation, valgus, flexion when they go to pick things up. And yeah, those might be risk factors, but because they're not predictive, it's not, well, everybody who does it this way is going to have this.
Yeah.
It's tough to, you can create the nocebo effect, or you can just, they're trying to fix something that's not broken yet can have other issues. So the way that I saw when I was reading the paper, it's like, well, if it's not painful, then we can just make sure that they're loading properly. They're staying with, below the injury threshold, and then everything's going up regardless, or almost regardless, of the way that they're doing the things, as long as that the dosage is proper.
Yeah, no, that's good. That's good, Travis. And in fact, that's what I mean. I think what you've hit on is one of the nuances of the physical stress theory compared to the more traditional approach, like the Kendall approach. Like, did you all study Florence Kendall in school? Is that a name that you've heard before? It looks like some of you had. When I came through school, Florence Kendall was like next to God with her views. Her and her husband, what was his name? Harry Kendall. And they wrote the book. They did the muscle testing. So she and her husband is the one who wrote the original muscle testing book, and just made tremendous contributions. She used to be at all the PT conferences, and the students just used to mob her. She's a delightful woman. But she had these pain syndromes, and that kind of separates what Chris and Travis, you're both saying, I think, is that her approach is that there is an ideal alignment, and we should all be striving for that ideal alignment. And the physical stress theory is not so, it de-emphasizes that. You know, it would pretend basically what you guys are saying, you know, that if that we do adapt to lots of different movement patterns, but when you can clearly see a movement pattern associated with pain, then that would be something you would want to try to address.
I thought you did a really nice job bringing that up in the paper, and then sort of laying out, well, that can contribute, but it's not the only thing. And questioning the ideal or good posture compared to the poor. Are you frustrated as a researcher clinician that it's 19 years later and that paradigm is still pretty prevalent, the good versus bad, when you pretty clearly had an understanding that it's more nuanced than that in 2002?
Oh, I guess I'm getting too old to be too frustrated. That's for you. That'll be good for you, Travis, and all you young folks to try to address that. I can tell you that things have changed dramatically over, you know, the 40 years that I've been practicing, and even in the last 20. So I think as a profession that we continue to go towards better understanding. And yeah, I guess just to answer your question truthfully, I am frustrated by some of the shallow perspectives I see, but then, you know, I'm tremendously encouraged by, you know what, there's 20 or 25 of you guys on this that are very thoughtful and, you know, are thinking these issues through. And, you know, you guys are the future of physical therapy and or rehabilitation. And so that's all very encouraging to me.
I was curious, could you throw Linda's name in the chat just so that I can look her up? Because I keep on hearing Linda, but I keep missing the last name. And then I have another question kind of related back to what Chris was talking about earlier with, you know, if you have someone who's in pain, then maybe you could say that that's a movement dysfunction because it's causing them symptoms. So like maybe that's something you should look into as far as correcting their movement, just to summarize maybe what Chris was getting at. But then I was curious how you balance that with fear avoidance later on. So I'm just thinking about like maybe Linda's paper where they're teaching people how to move, you know, quote unquote, better for a movement pattern. But then, you know, maybe for a tissue stress theory perspective, if they're moving now in this new movement pattern, now when they go to flex and pick something up, they're now maladapted to doing that because they've you know, dove into the more optimal movement pattern. So like maybe it's a question of how long you're seeing someone, and when it's no longer aggravating, you know, introducing a load like Jefferson curl or something else to get them adapted to both.
Let me see if I can answer it, Nicholas. You know, certainly people that have a high level of fear avoidance or hypersensitivity are a lot more difficult to treat. And I don't want to oversimplify I'm at the risk of oversimplifying it because there's always exceptions. But in general, I think, you know, the idea is to try to get them to move more. The fear avoidance is pathological. You know, if there's no physiological, you know, connection to it. And of course, who's to say? It's so hard to make that. But when it appears to do that, and I'm no pain expert, but from what I understand, you know, the basic approach, a behavioral approach, is simply to get people to move more and don't think about it. You know, I think we all kind of think too much about ourselves. We take ourselves too seriously. And in my experience, these folks are way over the top on that. You know, they just think about their pain too much, and they think about their problems. Now, I don't want to minimize because I don't want to be insensitive, and I don't want to say there's nothing there, but I think for the most part, you just need to help those people take the next step, and get moving. And whatever you can do to do that is good. I mean, it's the same with all of us, isn't it? I mean, I can be out working and cutting wood, and you know, I'll feel a twinge, and you know, I've got a choice. I can sit down and I can say, oh man, I can't cut this wood anymore. I've got this pain. Or I can keep chopping wood, and it's like 90% of the time I keep chopping wood and it goes away. Or, you know, you all who are athletes, you know, you get hurt in the heat of a you know, you keep going, and most of the time the body adapts, and you're able to, I've even done that during marathons before, where there's times when it hurt. I thought, man, this race is over, but I keep going, and then all of a sudden it's just gone. And so our body has this incredible way to adapt the motor control. You know, I can't help but think that there's different muscle fibers around the joints that figure out a way to unload, you know, the harmful stress, and we keep going. Now, I'm going to say again, that's a dramatic oversimplification, and it just doesn't work with everybody, and you have to be sensitive to them. But I would contend that principle is still true. And going back to Travis's question earlier, what would I do? The two areas that I thought I was going to write something about was central sensitization and all the work that's been done that, and then mechanical transduction. I mean, those are the two areas that I don't think the principles have changed, and that's kind of why I didn't rewrite it, because it didn't really have an impact on the principles. It's just that there was a great body of literature that supported those basic principles, at least, you know, in the way I've described it. And one could, you know, one of the criticisms I've heard from some people, which is a justifiable criticism, is that, you know, I've made so many, Katrina and I made so many modulating factors that, you know, you can account for just about anything. And there's a little bit of truth to that. However, I think, you know, as physical therapists, we need to think of those modulating factors as we think about how we manage people, especially those with hypersensitivity. But at the end of the day, it's all about how can I stress them to help them with their goals. And so I want to transition for just a second. The other point in the paper was the application. And so there's basically two forms of application. One is the person in pain, and your question becomes, well, what are the factors contributing to excessive stress on the tissue? We've talked a lot about movement factors. So is there a movement factor that's contributing to stress on the pain? And then what can I do to change that? So that's like one key question. And then the other key one is, you've got a patient with an amputation, you've got a patient with stroke, you've got a patient with a hip fracture, and you want to increase their tolerance to stress. You want to increase their functional capacity. And then the question becomes, well, what are the factors that are leading to their inability to move forward? Is it weakness? Is it, decreased activity? Is it hypersensitivity? Is it psychosocial factors? And then what can I do to modify those factors to increase stress on either the tissues or on their system as a whole, and help them to move forward? So those are the two big applications. How do I decrease the stress to allow the tissue to heal, or how do I increase the stress on either the tissues or the person to allow them to become more stress tolerant, to improve their functional activity?
Michael, I kind of had a question off of, you talking about the ability to heal, and you talked about the different adaptations that tissues can undergo. So there's the death, atrophy, maintenance, hypertrophy, and then injury. And I was, when I was reading through those, I guess I was kind of wondering where you thought, or if you think that like tissue repair, recovery, falls into any of those categories.
I'm not sure if I'm following, Kevin. What could you rephrase that again? Was it how did the tissues fall into the different categories?
Sure. Sorry about that. So after say injury, in my mind, I'm sort of thinking of like repair or recovery being another adaptation that the tissue can undergo. But is that split into like different categories of because we know that those I'm sorry, let me just mute real quick.
No, that's okay. You like kids.
I think he mentions, you mentioned recovery in the paper, and that there has to be adequate time to recover between bouts, but that's not one of the levels in the atrophy, maintenance, hypertrophy.
Yeah.
Yeah.
Yep. Thanks,
Yeah.
Travis.
Yeah, no, that's and that's a great question, and that's where it is different from everybody, and where the modulating factors came in, and that's why I kind of I said before, with the Star Trek, how many just have you watched old Star Trek? And what was the guy's name? It was a real crusty doctor, and he'd flip out this thing and he'd scan them and he'd know exactly where their tissues were. Raise your hand if you've seen that. Nobody? Oh, a couple of you, Kevin did. Okay, and Nicholas, a couple of you did. 3. They're a hoot to watch. So when you're bored sometime, find them on Netflix or somewhere else. But that's the most frustrating, ill-defined portion of the theory, because it doesn't define how you tell that. You really don't know when you're approaching overload or not, and it's going to be different with everybody for the reasons that we talked about. So here's what we did with the diabetic foot. We do it clinically, intuitively all the time, but with the diabetic foot, there's like zero opportunity for feedback, because they don't feel pain or pressure. All of a sudden you just have a wound. And so we did a step activity monitor on them, and we very carefully put them at 10% every 2 weeks, which is a lot lower than what I think healthy people are able to adapt to, but we didn't want to hurt them. So, you know, knowing where that person is in the adaptation process is extremely difficult. And it goes back to one of Chris's earlier questions. And I think that's why we understress people for the most part, because we don't know and we don't want to hurt them. So, you know, unfortunately, it's a great question. And I keep hoping there's some kind of like medical breakthrough that helps us to understand. We tried to do it with temperature testing and other kinds of things, but it's difficult. And again, it's difficult to the patients as well. And that's why, you know, the best example is with a overload stress with strength training. You know, we know pretty much 70, 80% overload with the sets and reps is okay for most people, but there's tremendous variation in that too. So that's where the kind of the art comes in with PT and rehab.
Michael, we can cut it here. I know you wanted to be done closer to that 60-minute mark, and I want to be respectful of your time, but I really appreciate you coming on and chatting about the paper.
Well, you're very welcome, and I appreciate the invite and the interest and your excellent questions. I mean, your questions are just dead on, and your comments are dead on. And so again, these are the kinds of conversations I like to have, and it makes me so optimistic for the future. So best regards in all your future discussions. I think it's great.
Cool. Thanks, Michael. Thanks everyone else for joining. Have a good weekend.
Thank you.
Bye-bye.